Hi everyone, I'm Dr. John Barbieri. I'm a board-certified dermatologist and epidemiologist at Brigham Women's Hospital and Harvard Medical School in Boston. In this video, I want to talk about how we can move from breakouts to bargains. How can we provide high-value care for our patients with acne? Structure this into three parts. First, why does providing this cost-effective high-value care matter? How we can approach mild to moderate acne, and then how we can approach moderate to severe acne. So when we talk to our patients, 3 out of 10 of them say they're not taking their medications as prescribed due to cost. This is a major issue. Costs are a huge factor for our patients. In dermatology, prior authorizations are a growing issue. Anybody who's seeing patients right now is dealing with this stress and challenges of prior authorizations. This was a survey that we ran through the American Academy of Dermatology a few years back, where we found that practices said they could see 5 more patients a day if they didn't have this stress and burden of prior authorizations. When we look at patients who never pick up their prescriptions who are primarily non-adherent, 65% of them say cost and coverage is a primary reason for them not being able to get their medicine in the first place. 20% of them just going through that prior authorization process, even if it's ultimately covered, is a reason that they were not able to start their medication as prescribed. And then patients are spending a huge amount on these treatments, hundreds of dollars a year on their acne care. And so if we can move to more high value care from patients, we're going to improve their adherence. They'll be able to get their medicine. They're going to be more successful, more satisfied. We're going to save ourselves time. If we are providing high value care, we're going to be doing less prior authorizations. We're going to be able to see more patients. We're going to have less stress. We're going to get fewer calls from patients saying that they couldn't get their medicine, that they need a less expensive alternative. So for all of these reasons, providing high value care for acne is incredibly important, and it's going to lead to better outcomes for both our patients and us. So just as some context, here are some prices. So these are some topical retinoids. You can see generic topical retinoids on GoodRx, usually in like the $30 to $50 range. Some of the branded ones can start to cost in the hundreds of dollars. In clascoterone, a topical androgen is about $500 on GoodRx right now. Topical antibiotics, again, kind of that $20 to $50 range for some of our more generic ones. The branded ones, hundreds of dollars, kind of that $500 range again. Combination products, look at adapalene benzoyl peroxide, very affordable, $20 to $30. We have some other branded combination retinoid benzoyl peroxide products, more expensive, $500. Clindamycin benzoyl peroxide, again, pretty inexpensive, $50 on GoodRx. And then we also have clindamycin tretinoin, which is now generic, about $90 on GoodRx. Moving on to systemic medications, oral antibiotics, doxycycline, minocycline are relatively affordable. In contrast, sarecycline is much more expensive. Spironolactone, again, very affordable. Isotretinoin, also pretty affordable. So now that we have that background and context, let's move into how I approach mild to moderate acne. So the first thing is we would love to just know what treatment is best, what works the best. We could just look at its efficacy over its cost, and we could just know its value. That would be simple, awesome. The problem is we don't have a lot of data about how these treatments compare to each other. There's just a total lack of active comparator trials where we look at is tretinoin or adapalene better for treating acne, or how does trifarotene fit into all of this? We don't have those studies. So in the absence of those studies, the next best thing we can do is to try to do these network meta-analytic techniques. And I'm going to kind of reference some of these studies throughout the presentation to help provide context when it comes to thinking about which treatments work best. And this is, hey, we don't have a comparison of tretinoin, versus clindamycin benzoyl peroxide, but we have a comparison of tretinoin and clindamycin versus clindamycin benzoyl peroxide. So we can use these nodes to compare these treatments against each other using some mathematical techniques. And this is one example of a network meta-analysis out of the UK. They look at a relatively limited number of acne treatments because these are what they have available in the UK. And not surprisingly, they find combination treatments like adapalene benzoyl peroxide work the best, clindamycin benzoyl peroxide next, then adapalene and tretinoin are pretty similar, and then benzoyl peroxide and topical antibiotics like clindamycin are a little bit lower than that. This is a larger study. This is one looking at more different classes of treatment. You can again start to see combination treatments tend to work the best. Then you have a lot of kind of your single agent topicals are pretty similar to each other when it comes to efficacy, just IGA success clearance. So let's just look a little more specifically at some of the data for some newer products. So trifarotene, it's a 4th generation retinoid. It's highly selective for the retinoic acid receptor gamma, and it's FDA approved for those 9 or older. In the clinical trials, they studied it for both facial and truncal acne. Like most topical retinoids, it works pretty well, particularly for comedonal non-inflammatory lesions. It works on the trunk as well, as we might expect. From a tolerability standpoint, this is a pretty potent topical retinoid, and it's pretty irritating. In the trials, 25% of people are having moderate erythema, scaling, and dryness. And this is a study comparing trifarotene versus tazarotene lotion and adapalene. You can see trifarotene is much more irritating than a lot of our other topical retinoid products. And I think this is what many of us who've used it in practice have experienced as well, that this can be quite an irritating product. And so if it's irritating, the question is, does it work better? Like tazarotene is more irritating, but it does seem to be more efficacious. Do we see the same thing with trifarotene? Well, in that network meta-analysis I was showing you, I'm not so sure. So we look at percent reduction in total lesion count. Trifarotene actually is the worst of any of the topical retinoids. In IGA success, it's about the same as adapalene. It's worse than tazarotene and tretinoin. And when we look at discontinuation due to side effects, again, compared to these other retinoids, it's by far the worst. Adapalene, as we might expect, is the best, similar to tretinoin, tazarotene a little worse, and trifarotene the absolute worst. So here we have the situation where, with the limited amount of head-to-head data that we can kind of create, we don't have a real head-to-head study, trifarotene seems more irritating, not clearly more efficacious, maybe if anything less efficacious than some other options, and it's much more expensive. And so this is an option where it may not be the most high-value treatment. There may be some who need a really potent retinoid where it's good, but for most, our generic topical retinoids, adapalene, tretinoin, tazarotene, are probably going to be able to get the job done just as well, if not better. But what about some of these other newer ones? What about encapsulated tretinoin benzoyl peroxide? This is a cool idea. If you microencapsulate these, they're stable together. It might improve tolerability, like what we see with encapsulated benzoyl peroxide and rosacea. It's again FDA approved, 9 years of age or older. In the clinical trials, it works pretty well. There's about a 20% greater rate of IGA success compared to vehicle. For instance, for trifarotene, is about 10 or 15%. It works, very well for comedonal lesions, like we might expect. Just for some comparison, here's the adapalene benzoyl peroxide trials. So you can see here that there's again about 20% difference in IGA success at week 12. So it's not clear to me that this really has a clinical advantage in efficacy over our generic adapalene benzoyl peroxide I showed you before, $25, $50. From a tolerability standpoint, a few people discontinued due to adverse events, 3%. That's pretty similar to what we see in those adapalene benzoyl peroxide trials. So again, not sure that this has an advantage from tolerability. It might. It certainly has some theoretical advantages with microencapsulation, but when we just look at the clinical trial data, I'm not necessarily convinced. So again, here we have a product that it's not clearly more efficacious, it's not clearly more tolerable, and it's way more expensive. So until someone does that head-to-head study of this versus just regular adapalene benzoyl peroxide, this isn't something I necessarily would think makes a lot of sense as a high-value practice to use. What about tazarotene and tretinoin lotion? So the idea of this is if we take these medicines and we put them in a vehicle that distributes them more slowly on the skin, this is kind of similar idea to microencapsulation, we can improve tolerability. And we do actually have a study, a phase 2 study of tazarotene lotion versus cream. The efficacy are similar, and the irritation is about half with the lotion. So this lotion vehicle does seem to help improve tolerability. And so for patients who have trouble tolerating tretinoin or tazarotene, especially tazarotene, which can be really irritating, these lotion formulations might be a valuable option for us to make these treatments more tolerable for our patients. And although they do come at a higher cost, they do seem to provide some benefit. And so for patients who need that, I do think they can be a valuable treatment option. What about clascoterone, topical anti-androgen? This you can use in both women and men with acne because it's just topical, it's unabsorbed. So this is really the first treatment we can use in male patients to address the fundamental hormonal causes of acne. In the phase 3 trials, it works quite well. It has about 20% IGA success versus about 8% with vehicle. This is similar to what we see for most single agent trials, about 10 or 15% better than vehicle. It works particularly well for inflammatory papules and pustules, it seems like. It has basically no clinical side effects. People don't get irritated or dry from it, which is great because so many of our acne treatments are limited by tolerability. This could be a nice option for those with more sensitive skin. It does have an important risk of adrenal suppression. This is with extremely high use. In the study where they showed this, they're using 6 grams in application. You'd use the whole tube in about 5 days if you're using that much with each application. That's a lot of medicine. And when they did that, 7% of people had a biochemical abnormal HPA axis response, a biochemical evidence of adrenal suppression. Nobody had symptoms. Nobody in the phase 3 trials had symptoms. So I don't think this is a major issue, but I wouldn't recommend using this over very large body surface areas. And this issue is because the medicine gets metabolized in the skin to cortexolone, which is like a steroid. We do have one phase 2 head-to-head study of clascoterone versus tretinoin 0.5% cream. And in fact, actually, clascoterone, this black bar, is basically numerically superior to tretinoin at every endpoint, and a few of them even statistically significantly superior. So this is, an interesting option. I think it probably is somewhat similar in effectiveness to topical retinoid single agent treatment. I don't think it's the most potent ever. You're gonna be able to fix anyone's acne with it, but it's a great complementary option to our other main treatment modalities of topical retinoids, topical antibiotics, and benzoyl peroxide. And it's very tolerable, so it's good for those with sensitive skin. And it might be more effective for those who have PCOS or stronger hormonal drivers of their acne. Again, looking at our network meta-analyses, so if we compare it to just in general other topical retinoids, it's pretty similar, maybe a little bit worse, but about the same in this network meta-analysis. It has actually higher rates of IGA success, so clear, almost clear, compared to these topical retinoids and other acne treatments. And look, very low rates of discontinuation due to side effects. It's a very tolerable treatment. So I do think this is a valuable option in our treatment armamentarium. It complements other treatments. It's tolerable. It is a twice-a-day medicine, and it's a little bit of a thicker vehicle. So from a usability standpoint, it has some limitations, but I think it's a very useful option for our patients. And while it is more expensive, for the right person, it can be very valuable. All right. What about minocycline foam? So this is a new topical antibiotic, very high concentration. The idea is you can try to prevent bacterial resistance by having this high concentration on the skin. In the phase 3 trials, it works okay. It's about 5–10% better than vehicle. It's not, knocking my socks off compared to some of the other things we've seen today. It had very tolerable, like most topical antibiotics. But again, we don't really know how well this compares to standard of care things like clindamycin or erythromycin. I think for the typical patient, it's not clear that this adds a lot of value. It doesn't have particularly impressive phase 3 trial data. So again, without that head-to-head study, I'm not sure it's worth the extra cost and extra hassle of trying to get this versus just using clindamycin lotion or solution for most patients. So to summarize, generic combination products are often highly cost-effective and convenient for patients. They can have high rates of adherence, and they work quite well. And adapalene benzoyl peroxide is the main one I would suggest using. Topical antibiotics like clindamycin or dapsone, I think, are going to be helpful for those with more severe disease, especially inflammatory lesions, or where I think antibiotics really shine. Clascoterone, super well tolerated. We can address that hormonal pathogenesis of acne. It's a new mechanism of action that's always exciting. We also don't want to forget about macular hyperpigmentation. I didn't talk about that much today, but things like azelaic acid, glycolic acid, and retinoids can be helpful here. And I really don't use a lot of these other medicines as first-line options. We don't have a lot of data that they're that much more valuable than any of these low-cost generic treatments. I think my main exception would be tazarotene and tretinoin lotion for those who have truncal acne or more difficulty tolerating retinoids. All right, what about more moderate to severe acne? So, oral antibiotics, they're kind of our bread and butter treatment for acne, but they certainly have limitations. They can cause antibiotic resistance and other harms like increased risk of breast and colon cancer and disruption of the microbiome. This is just an example of how quickly they can disrupt the microbiome. This is a study from Anna Chan's group, and they looked at people who were given minocycline for 4 weeks. They looked at their microbiome before and after, and then for several weeks beyond that. You can see that C. acnes goes down with oral antibiotics. That makes sense. It's one of the ways that it helps to treat acne. But look, gram-negative bacteria really spike by 4 weeks of use, and that might explain that gram-negative folliculitis that we can see with antibiotic use for acne. And it does seem to over time return. But we can see these changes happen quickly. They happen within a few weeks. Strep abundance increases and stays elevated in this study even after people have discontinued the antibiotics, and that might explain this association with strep pharyngitis. And there's heterogeneity between patients. Different patients have different kind of reactions in terms of their microbiome. This is another study looking at resistance with low-dose antibiotic regimens and higher-dose regimens. And you can see even with doxycycline 20 milligrams a day, patients are developing resistance at both doses. So I know often some people will say, oh, low-dose antibiotics, submicrobial, don't worry about it. But even these low-dose regimens can have meaningful impacts on our patient's health. So with that background, we now have a new antibiotic, sarecycline. And the idea is to make it a more selective tetracycline, make it really good for acne, really bad for other things, with the goal being you can reduce those off-target effects and maybe some of those side effects. So we can see here, this is looking at minimum inhibitory concentrations. The lower it is, the more effective that antibiotic is against that bacteria, the higher, the less. We can see sarecycline is really good against C. acnes, on par with doxycycline and minocycline. It's got a little bit less activity against some gram-positives like staph and strep, only about 2 or 4-fold. Is this clinically meaningful? Maybe not, but a little bit less. And it's got much less against gram-negative bacteria. So, some of them 8, 16 times higher MICs than doxycycline or minocycline. So this might help reduce some of those issues with gut microbiome and other off-target effects. We don't have a lot of in vivo data. This is in vitro data, but certainly this is a theoretical advantage of sarecycline. So how well does it perform in clinical trials? Well, it has pretty good rates of IGA success, about 20. This is kind of what we see in acne trials, about 10% more than placebo or vehicle. This is often what we see. It works really well, particularly for inflammatory lesions, which is often the case for antibiotic therapies, less so for non-inflammatory comedonal lesions. It's pretty well tolerated. Some patients have some nausea or abdominal pain. A few people have yeast infections. We don't see any evidence of vestibular adverse effects like we see with minocycline. It doesn't appear to be phototoxic in the clinical trials like we see with doxycycline, but in practice, I think it is a little bit phototoxic. It's probably not as much as doxycycline, but it's not none either. So it's pretty well tolerated. So just to summarize kind of how I think about, but again, we don't have head-to-head studies. We don't know how much better it is than our other oral antibiotics. So where do I put all this together? So first off, I focus more on limiting who we treat than how long. As you can see earlier, microbiome changes happen quickly, and they happen as soon as 4 weeks. This 3 to 4 months thing is very arbitrary. It's not particularly based on a lot of data or evidence. It's not like 2.9 months, you're fine. You hit 3.1 months, suddenly everything's bad. It happens much faster than that, and it tends to stabilize. So I think the decision to be on it or not is much more important than how long. I think for most people, doxycycline 100 milligrams twice a day is a good first-line option. It has similar efficacy in most studies. It seems to be safe for the minocycline, other than that phototoxicity issue. And we're dermatologists, we should be able to handle that. And I think sarecycline is a useful option for those who have limited options. They've failed other antibiotics. They've got comorbidities. They've got gut health issues, or maybe we're end up with more long-term use because we're not able to get off antibiotics and we're limited in other options, like they can't tolerate Accutane or something else. So I do think it can be a useful option, but it's not, I think, for everybody. But what about non-antibiotic alternatives, right? We just talked a bunch about limitations of antibiotics. The simple solution here is don't use them. And actually, that's what patients want. In this survey of patients, about 50% had received an antibiotic for the past year, but 3/4 of them would prefer a non-antibiotic option if one existed. And very few of them are actually aware of these options. So hormonal therapy is one option to do this for female patients with acne. This is a study from Ariel Nagler's group. And the first thing they found is those who at any point got a birth control pill, combined oral contraceptive, or spironolactone, they received nearly 3 months fewer days of treatment than those who didn't. And additionally, look at kind of changes in treatment over time. Most patients start on antibiotics. That's what you see in a lot of studies, but they tend to end up on hormonal treatments over time in this population of female patients with acne. So if we're going to end up there, should we start there? How well does spironolactone work, and how does it compare to oral antibiotics? So it can be really highly effective. This is a trial from Japan where patients were treated with 100 milligrams a day, and this is just monotherapy spironolactone. I think that's a pretty impressive result. We don't have a lot of randomized controlled trials, but we do have a number of case series that suggest that spironolactone can be effective for acne. I find this Isfi-Jubert one really interesting, where 60% had relapsed after isotretinoin, and among those, 71% had a good response to spironolactone. So I do think, and I've experienced this, there are these patients who are hard to clear with isotretinoin, or they relapse quickly, and spironolactone can often work very well for them. We do now have some randomized controlled trial data. This is the SAPHA trial from the UK. In this study, patients were randomized to either spironolactone 50 milligrams and escalating to 100 milligrams for 24 weeks, or placebo. And what they found was that 24 weeks, there was improvements. They looked at patient-reported outcomes as their primary outcome, the acne qual. So after 24 weeks, there was a significant improvement in acne qual with spironolactone compared to placebo. And interesting, if you look at IGA success, if you look at the clinician-reported outcome, there's really big differences. And I think this highlights that sometimes it can be hard to show significance of patient-reported outcomes in clinical trials. What's really useful here is the side effect profile data we now have. So, one thing we worry about is irregular periods. In this study, it really didn't seem to be a major issue at 100 milligrams a day. There was an increased rate of dizziness, lightheadedness, and headache. I think this goes to those blood pressure effects. And then people did have a little bit higher rates of polyuria going to the bathroom. So I think these are useful data for us to better understand the side effect profile. About 5–10% of people have some issues with lightheadedness, it seems like, based on these data. Now, we don't have any studies comparing spironolactone versus oral antibiotics yet. We're currently running that trial, and we hope to have some results in the coming years. But we do have observational data. This is a study where we looked at people who started on spironolactone versus those who started on oral antibiotics. And what we find is that rates of changing treatment, going to something different, are similar between these groups. And that kind of suggests that these treatments work about equally well. If you're just as likely to have to change to another treatment with one as another, they're both relatively effective. So, in this study, we found that there was no significant difference in treatment switching between these two options. And it suggests that spironolactone might be a treatment we can use instead of oral antibiotics for female patients with acne. This is work from Rasmus Sagimi suggesting that lab monitoring is not required in young, healthy women. They found that there are similar rates of abnormalities at baseline as on treatment, and it wasn't really changing management, and that suggests a low-value practice. But what we found is that lab monitoring is a very common practice still. About half of people are checking them at baseline, and about 40% of people are monitoring them regularly while people are being treated. So there may be an opportunity to reduce monitoring to improve outcomes in this population and reduce cost. A common issue that comes up is, can you combine spironolactone and drospirenone containing combined oral contraceptives? And I would say the answer is yes. The simple way to think about it is 3 milligrams of drospirenone is like 25 milligrams of spironolactone, and most of us wouldn't worry that much about increasing the dose by 25 milligrams. The other way to think about it is there's a couple of studies that have looked at risks of hyperkalemia with concomitant treatment and haven't found any evidence of increased risk. Another common question is risk of cancer. This is a meta-analysis from our group where we don't really find any signal for increased risk of breast cancer spironolactone use. I do worry a little bit about ovarian cancer. Although it's not statistically significant, there's a lot of imprecision here. So I think in someone who's at elevated risk of ovarian cancer, maybe has a BRCA mutation, you might want to be careful about spironolactone use in that population. But ovarian cancer is relatively rare, so the number needed to harm is going to be very high. The absolute risk is going to be pretty low. So who's a candidate for hormonal therapy? I would say really almost any female patient with acne. All acne is hormonal. When you actually look at adult women with acne, their acne often looks more like adolescent acne than like this lower face jawline type of thing that we talk about. All right. In the last section, I want to talk about lab monitoring with isotretinoin. So one of the reasons that we check labs is to prevent adverse events or to guide dosing. But the downside to this is that it can cause pain. It can make patients nervous. They go, oh my gosh, this medicine must be scary. And it's expensive for them to get labs, especially with high deductible plans. So this is a study where we looked at about 1,800 patients treated with isotretinoin and looked at their labs. We found that clinically meaningful lipid abnormalities are very rare. Only about 0.3% of people have these grade 3 or higher abnormalities. And among those who do, many of them keep going. Notably, the reason we talk about this is concern of pancreatitis. And most people who've had pancreatitis haven't had elevated triglycerides, and it's exceedingly rare. And so when you put that into context too, kind of highlights that this might not be that high value of a practice, as it's unclear that we're actually preventing that outcome we care about. Similarly, we don't really find any evidence of LFT changes. They're just as common at baseline as on treatment. And there really hasn't been a lot of reports of true hepatotoxicity, like really meaningful elevations in AST or LFT or lasting liver injury. And so again, LFT monitoring actually might be of kind of limited value too. We don't find any CBC changes, and actually in the updated guidelines, we recommend against checking CBC. And then CPK is the tricky one. Certainly people can have rhabdomyolysis with isotretinoin, but CPK is a really, really high, not very specific lab. You just go on a run, you can have elevated CPK. So I think it's something that's just impractical. If we had a better test for looking at risk for myalgias or rhabdomyolysis, that might be useful. I just don't think this is that test. This is a Delphi consensus that we worked on where we recommended checking just labs at baseline and peak dose, just ALT and triglycerides, or you could do liver function tests and lipid panel. So my approach is really, I don't check any blood counts. I don't think there's evidence to support that. I don't check CKs. I think it's just impractical because of the false positive rate. And I think checking intermittently an ALT and triglyceride at baseline peak dose, that's kind of my standard. But in patients who really understand the risks and the benefits of lab monitoring and would rather not do it, I'm okay with just monitoring and not actually doing any specific lab testing. And if we just went from what we do now to that baseline and peak dose, we'd be saving hundreds of millions of dollars a year in the United States. To summarize, generic adapalene benzoyl peroxide are great initial topical options. I think Sacera has some advantages, but for most patients, doxycycline is fine. Hormonal therapy can be a low-cost option for women with acne, and we should reduce our lab monitoring for isotretinoin. If you found this video helpful, pop that like button, consider subscribing to the channel. That really helps us out, and I appreciate it. Please ask me your questions about acne in the comments below, and check out some of the other videos on our channel to learn more about acne and rosacea. Until next time, see ya.